So the title of this topic I've been asked to speak about is Tumour Markers in Lung Cancer. And I think what we're going to focus on today is really how to incorporate some of the novel data on the molecular features of lung cancer and how we incorporate that into our diagnostic and treatment paradigm. So today I'll be talking about, starting with a bit of epidemiology, putting it into context, talking about targeting the EGFR receptor signaling axis, ALK translocations, some very new data about ROS1 translocations, the implications of KRAS mutations in lung cancer, a little bit about squamous cell cancer, and some conclusions. So we're really going to be looking into the molecular classification of lung cancer in this talk. So I thought I'd start off with a bit of epidemiology, putting lung cancer into context in Lebanon. And these slides, courtesy of Dr. Shamsuddin at the AUB, are data from the Lebanese Tumor National Registry, showing that the incidence of lung cancer is in fact increasing in Lebanon, as with all smoking-related tumours. We can see here from the data, the last data in 2007, lung cancer is the third most common cancer in Lebanon, but in fact its incidence is rising. This is in men, and also in women, with the increasing prevalence of smoking, the increase in lung cancer in women is also quite marked. Now the third highest cancer incidence in Lebanon. Okay, so traditionally we all know lung cancer histological classification, dividing things into small cell or non-small cell initially, and then broadly into adenocarcinomas, squamous cell carcinomas, and large cell or unspecified. So already we are using the histological classification to guide our treatment. For early stage lung cancer, whether the cancer is a squamous cell or an adenocarcinoma, treatment options are generally very similar. We do not tend to stratify our treatment based on histological subtype in non-small cell lung cancer. But what about advanced disease? Certainly in advanced lung cancer, we are now dividing patients into squamous or non-squamous histologies for treatment. We know that the patients with adenocarcinoma have different outcomes with certain chemotherapy drugs, so we're already using that classification to guide our treatment. So this is really a pictorial diagram about our current classification. If we look at our lung cancer 100 lung cancer patients, dividing them into adenocarcinomas, large cell, squamous cell, and small cell, it might look a bit like this if they're coming into your clinic. But how do we change from this histological classification to our molecular classification? And does this matter? Is this relevant to pulmonologists, to clinicians, to oncologists? We might in the future be, instead of dividing patients purely on their histology, looking at their molecular markers and looking at their molecular classification. So we might find a proportion of our patients with EGFR mutated lung cancer, ALK translocations. There was a report recently in the JCO this week, the Journal of Clinical Oncology, about a small proportion of patients with HER2 overexpression. We know that's very important in breast cancer, and patients with HER2 overexpression in lung cancer can benefit from HER2 targeted therapy. So how do we make this change? And again, does it matter? Is it relevant to us? How do we change from this purely histological classification to our molecular stratification? So let's think about lung cancer treatment. Our treatments at the moment are generally surgery for early stage disease, as you know, radiation therapy and chemotherapy in various combinations. But how can we improve? How can we cure more patients? How can we help patients live longer with a better quality of life with advanced disease? These are the challenges facing us today. So let's talk about targeted therapy. Targeted therapy is a buzzword in oncology. We're all looking for targets. We're all looking for the latest targeted therapy. What do we actually mean by that? We mean drugs targeting pathways and processes and physiology that's uniquely disrupted in cancer cells. So rather than normal tissue, we're targeting the cancer cells. And these can be against receptors, against genes, and against angiogenesis. So are we using targeted therapy in lung cancer? Well, we have started. We currently use Avastin or bevacizumab targeting angiogenesis. We are currently using drugs targeting the epidermal growth factor receptor. Those are oral drugs, erlotinib, Tarceva, and gefitinib, or Iressa. And we also recently have the latest drug in our armamentarium, which is crizotinib, an oral ALK inhibitor. So if we're going back to our molecular classification, again, how do we go about doing this? It's all getting a bit more complicated, and this slide shows us some of the subtypes, molecular subtypes of non-small cell lung cancer. And it's mainly in the field of adenocarcinoma that we have made most progress in molecularly classifying this disease. Still, a large proportion of driver mutations are unknown, but a significant proportion of patients with adenocarcinoma have KRAS mutations, EGFR mutations, and smaller numbers have ALK translocations, ROS1 rearrangements, HER2 or ERBB2 overexpression, and derangement in other signaling pathways like the PI3 kinase pathway. So let's talk a little bit about how we incorporate this new data into our treatments. So we come to the question, we have all this data, is it relevant? Is it relevant to our patients? Is it relevant to you as clinicians? Let's go and talk about the most developed line, first of all, which is EGFR mutations, looking at the initial assessment and treatment of lung cancer. So EGFR mutations are found in approximately 10 to 15% of Caucasian patients. The majority of those will have adenocarcinoma, but they're much more frequent in Asian populations. By Asian, we mean Chinese, Southeast Asian, Japanese patients. The percentage of patients in Lebanon with EGFR mutations, we're not really sure. We haven't done a national study, although some data from the AUB is being collected, and that will emerge. I'm not sure if any of you in your practice have any thoughts about how many patients with EGFR mutations you're seeing. But really, this is something which we should be testing in all our patients with non-small cell lung cancer adenocarcinoma, because it really is going to change their treatment. As I mentioned, we have 2 oral drugs targeting EGFR, Iressa and Tarceva, and these are generally very well tolerated. Unlike cytotoxic chemotherapy, they don't cause myelosuppression, they cause less fatigue, less side effects, they can cause some diarrhea, they can cause a very characteristic acneiform rash. So this is one of the characteristics of EGFR targeted therapy. We see this also with monoclonal antibodies targeting EGFR. And it can be related to treatment response. So if your patient is on Tarceva and they're not getting a rash, this is when we need to worry that we're really hitting the target. And this slide just shows the grades of rash, and it can be extremely severe in some cases. So how did we develop these treatments? Well, actually, the drugs were developed before we really knew much about EGFR mutations. And at the beginning, we were testing these drugs in unselected patient populations. We knew that there were some clinical features that helped us select which patients might respond to Tarceva or Iressa. And these were patients who had adenocarcinoma, patients who were non-smokers, who were female, and of Asian origin. And now it emerges that those patients are much more likely to have EGFR mutations. The pivotal trial that led to the approval of Tarceva as a second and third line treatment in lung cancer was the BR21 study. This was conducted by Francis Shepherd in Canada. And although this was an unselected patient population, in Canada they had actually quite a large proportion of patients with a Southeast Asian background. So probably in this population of patients, they had more patients with EGFR mutations than would be seen in a general North American population. And this study showed that erlotinib versus placebo, second or third line, prolonged progression-free survival and overall survival, leading to the approval of the drug. What about first-line treatment? We know that the IPAS study was a key study in the approval of EGFR-targeted therapy in the first-line setting. And again, this study was conducted in Southeast Asia. But before the study started, we didn't know much about EGFR mutations. So the patients were selected on clinical grounds, those who had adenocarcinoma and never or light smokers. They were randomized first line to either Iressa, gefitinib, or chemotherapy. And these were the progression-free survival curves. And if we look, we can see that these curves overlap. And generally, when we see overlapping curves, this probably means that there are two populations of patients with two different responses. And sure enough, when we learned more about testing for EGFR mutations, we could separate these patients into those who had EGFR mutations and those who didn't. For patients who had EGFR mutations, they had a significant benefit from gefitinib given first line. They also had a better prognosis overall compared to the EGFR mutation negative patients. Those patients who didn't have an EGFR mutation did really, really badly. We can see, I don't think I've got a pointer here, we can see the this red line of gefitinib. Patients who do not have an EGFR mutation do very badly with EGFR targeted therapies first line, and they're much better off with chemotherapy. So suddenly we have a drug, we now have a biomarker for treatment selection. It's both prognostic, because patients with EGFR mutations tend to do better overall, and it's predictive of treatment effect. So this is the ideal biomarker. And what happens when we give patients with EGFR mutations these oral, low toxicity therapies? They can actually respond extremely well. And here, all oncology presentations have to have some of our best responders. And this is a patient with extensive non-small cell lung cancer with an EGFR mutation treated with gefitinib, who is actually stable for many years. Okay, so now we are getting a bit smarter. We're managing to stratify patients based on their mutation status up front. And this is something which we're now doing in the clinic. So now we really are at the stage where all patients with non-small cell lung cancer adenocarcinoma should have their EGFR mutation status detected up front, because we now have data that patients really do better if they have a tyrosine kinase inhibitor first line. In this study, they randomized patients with known EGFR mutations to either gefitinib or chemotherapy. And as expected, the patients on this red line here who had the gefitinib first line had a very significant prolongation in progression-free survival. And here we just have a summary of clinical trials carried out in Southeast Asia, patients with EGFR mutation positive, all showing consistently that EGFR targeted therapy first line is of great benefit to these patients. So what are the future directions? We now know that EGFR tyrosine kinase inhibitors can be used first line for mutation positive patients. They still are licensed second line for patients with unselected, although we know that the patients with EGFR mutations will do better. And we also have evidence for use as maintenance therapy. What's next on the horizon? Well, we're developing newer and better drugs. So the second generation of EGFR tyrosine kinase inhibitors, you'll hear the names of drugs such as afatinib and dacotinib. These are irreversible inhibitors rather than the reversible inhibitors of the first line agents. And these also target not only the epidermal growth factor receptor, but also other receptors in the same family, like the HER2 receptor. We're also looking at the added value of blocking additional pathways. So we know that MET amplification is very important in EGFR tyrosine kinase resistance, and blockade of MET is probably going to be very important in the continuing response of these patients to targeted therapy. So watch this space. Next, we're going to talk about some of the newer data emerging about subclassification of non-small cell lung cancer, talking about ALK rearrangements and their role in therapeutic selection. So what is the ALK translocation? Well, this is actually really a success story in drug development. The ALK translocation was first described in 2007, and now in 2013 we have a novel drug that's been approved for use. So really this is very rapid in the field of drug development. So the ALK fusion causes activation of abnormal signaling pathways. So this becomes the driver mutation in a small but significant minority of non-small cell lung cancers, again mainly adenocarcinomas. We looked at a phase 1 trial, this was presented in ASCO 2010, took patients who had this ALK translocation and treated them with a novel tyrosine kinase inhibitor called crizotinib. This targets the ALK abnormality, also targets NET, so it probably has several different functions. But for these patients who had advanced disease, this is a waterfall plot, and this shows individual patients and their responses. So for patients who are identified as having this ALK translocation, the majority of them had a significant response to treatment. So all of these patients below the dotted line had a confirmed partial or even a complete response to treatment. This is really something very, very unusual in the treatment of advanced lung cancer. And it really does emphasize the concept, if we can find that target, that driver mutation, and we can block it with a targeted therapy, we can really improve outcomes for these patients. Okay. So disease control rate of 87%. This is really something very much unheard of with cytotoxic chemotherapy. And again, we have to show some good pictures. This is a patient started on 2009 in the study with an ongoing response in 2012 with an oral, fairly non-toxic treatment. So this is just to describe to you how rapid the progression and development of this drug has been. So in 2007, we identified the translocation, the target. We had some preclinical studies, and then in 2009, the first clinical data emerging. And in 2010, we had the first studies being presented at the oncology meetings. And then actually in 2011, the FDA approved crizotinib for the treatment of ALK-positive non-small cell lung cancer. So how many patients with non-small cell lung cancer have an ALK mutation? We're probably only in the region of 2 to 3% of patients. But worldwide, that is still a large proportion of our patients with non-small cell lung cancer, and it is certainly a very significant therapeutic benefit. So now we have crizotinib available in Lebanon, and we also have the ability to test for the ALK translocation. So we're now moving on with our molecular classification. All patients with non-small cell lung cancer adenocarcinoma should have EGFR mutation testing and testing for ALK rearrangements. What about other rearrangements in lung cancer? Are there any other targets, any other driver mutations? And there are some very recent data regarding ROS1 rearrangements. These data were presented at the ASCO Oncology General Meeting in June this year, so this is latest early phase data. ROS1 chromosomal rearrangements, again probably in 1 to 2% of non-small cell lung cancers, cause abnormal tyrosine kinase activity, abnormal proliferation, and in a phase 1 dose escalation study, these patients also responded to this same targeted treatment of crizotinib. Only 15 patients, we're talking very early study here, but they had a very impressive response to treatment. And if we look at the clinical activity in the ROS1 positive patients, their response rate was almost 60%, which correlates with the patients who had ALK positive non-small cell lung cancer. Disease control at 8 weeks, over 80% of patients had no progressive disease at 8 weeks. So again, these are extremely early data. These have only recently been presented. But again, it's the principle of finding yet another driver mutation in non-small cell lung cancer that we can target with an oral targeted therapy. Crizotinib has acceptable toxicity profile, much preferable to cytotoxic chemotherapy. But of course, we need a bit more clinical data, a bit more information about the frequency of ROS1 rearrangements, and how we're going to test for those, how we're going to make that clinically useful. So currently, we don't test for ROS1 rearrangements, but that might be something that's coming on into a panel of testing that we send our tissue for. So what about KRAS? If we go back to our original diagram, a significant proportion of adenocarcinomas have a KRAS mutation. We know that's very important in colorectal cancer. Patients with KRAS mutated cancer tend to do not so well with EGFR targeted therapies. But what does it mean in lung cancer? And there really are some conflicting data about the prognostic implication and whether we can therapeutically target this. Again, recently presented in June this year, we now have another new drug which is a selective inhibitor of MEK1 and 2. These are downstream targets of KRAS. And potentially this can be added to chemotherapy to increase the efficacy of patients with KRAS mutated, locally advanced or metastatic non-small cell lung cancer. Again, looking at this very, very early data, patients had a significantly increased overall survival with the addition of this targeted therapy with chemotherapy. These are very small numbers. And the conclusion was that new targeted therapy in combination with chemotherapy could significantly improve median progression-free survival in KRAS mutated non-small cell lung cancer. What about squamous cell carcinoma? Again, we haven't heard much about squamous cell carcinoma. These are our patients who are smokers. All the focus has been on adenocarcinoma and non-smoking patients. Again, very recently, Nature, September 2012, we have seen genomic characterization of squamous cell carcinomas, and several important driver mutations have been identified. TP63, SOX2 mutations, and again, very early stages. We don't have any therapeutics targeted yet against these mutations, but in the future we can see the developmental pipeline looking at targeted therapy for squamous cell carcinomas. So let's go back to our classification. What does this all mean? What does this all mean to clinicians? Is it relevant? We still have not let go of our formal histological classification of lung cancer, but we certainly have added EGFR mutations and ALK translocations to the necessary data set in order to give our patients the best possible treatment. And if we look about the goal of personalised medicine, we really want to, in the future, be genomically classifying our patients at diagnosis so we can select for them the best treatment. We also need to consider that whether we use these treatments earlier in the disease treatment paradigm, whether we can actually cure more patients if we add these treatments neoadjuvantly, if we use them adjuvantly after surgery, are we going to cure more patients with this disease? So these are my conclusions. For non-small cell lung cancer, adenocarcinoma, EGFR mutation testing and ALK translocation testing are now standard of care. These are available here in Lebanon. Often they can be funded by the pharmaceutical companies, so the patient is not out of pocket, and this will really have important implications for therapy. The molecular classification of lung cancer, of all types of lung cancer, is certainly on the horizon and something we'll be seeing a lot more about in the future. Every year, new drugs, new targets are being discovered and tested in clinical trials. Insights into the molecular biology of lung cancer are now being translated into improved treatments for patients, and hopefully with our goal of curing more patients and helping patients live longer with good quality of life. So we come to the end of our conclusions. I thought we'd leave some time for any questions.
I have a question, please. In your experience right now in Lebanon, do you think they are doing these two randomly or on every single biopsy they are getting? I'm talking about the pathologist.
So the EGFR mutation testing needs to be done by our genetic service. They can do that on paraffin-embedded tissue, and routinely we are sending patients for EGFR mutation testing. ALK translocation testing takes another request, but certainly we have the ability to do it.
And can it happen to have both the translocation and the mutation in view of the risk factors and all that?
Currently, we haven't seen patients with EGFR mutations plus ALK translocations. It seems to be different driving mutations. Also, EGFR mutations and KRAS mutations tend to be mutually exclusive. So patients generally have one mutation or translocation which is driving the disease, and it's just a question of picking that out. We can imagine in the future we might have some sort of multiplex assay where we send the tissue and perhaps with the advent of whole genome sequencing, whole exome sequencing, we might be able to do this very rapidly and at low cost in the future. We're not currently there with the technology yet, but this is what will come in the next 5 years. Again, this brings us back to the point about tissue, because often we're using very, very tiny tissue samples, and on that small tissue sample we need to have the histological classification, immunohistochemistry, and if we want to have molecular classification as well, we are running out of tissue. So I think certainly for patients who are physicians who are diagnosing lung cancer, having a good tissue biopsy is even more important than ever before.
Question, please.
Yeah. Pierre Youssef, thoracic surgeon. My question is, with using new technique as EBUS, it is possible today to have a fine needle aspiration and to send it or to test it for a mutation or not?
Yes, we are exclusively now using EBUS in many patients, and it is certainly possible to get enough tissue for EGFR mutation testing. There's a lot of experience from the team I was working with previously at Guy's Hospital using EBUS and EGFR mutation testing. So yes, it is possible, but we do need enough tissue.
Question, please.
Thank you very much. Does this EGFR have a predilection on the basis of race? Is it racially driven or ethnically driven?
We're certainly aware there are racial differences, and the patients from Southeast Asian origin have approximately 50% EGFR mutations in adenocarcinomas, so it's much, much more common. So yes, race is very important, and also sex. So female patients have an increased rate of EGFR mutation compared to male patients.
Any more questions? Well, thank you, doctor, for this very interesting
Thank you.
topic.